Hi, everyone. Welcome. My name is Allison Bodenheimer. I'm Family Planning Technical Advisor for FPI2030 and the Knowledge Success Project. It's my pleasure to kick off this webinar on postpartum and post-abortion family planning indicators, which will revisit recommended indicators and share learnings from experts in implementing those indicators in Nigeria, Burkina Faso, and Rwanda. Please feel free to introduce yourself in the chat box with your name and where you're joining from. Slide, please. Just a note on logistics before we get started. Please also make sure that you select your language. First, click on the bottom of your Zoom window where you see the globe icon shown in the screenshot here, and it will take you to the English or French channel. You can then mute the original audio, which is helpful. Everyone needs to select a language to ensure that you're able to listen to all of our speakers, as we have some presenting in French and some in English. And in addition, you might want to select whether or not you'd like to read captions during the session. You should be seeing these captions automatically, but if not, you can select them by clicking on the icon with the two C's. If you wish to hide the captions later, please select the same icon again and select Hide Subtitle from the menu that appears. These captions are generated using an automatic feature in Zoom, so they might not be 100% accurate. On the Zoom platform, captions are only available in English at this time, unfortunately. Next slide, please. With that, I'm pleased to introduce the moderator for today's webinar, Alain Damiba. Alain is Senior Health Advisor at the USAID West Africa Regional Health Office in Accra. Until recently, he was the Senior Vice President for the Global Programs and Technical Leadership Offices of JPIGO, an international nonprofit health organization affiliated with Johns Hopkins University. And in this role, he provided strategic leadership and oversight for JPIGO's program quality and compliance, and oversaw program planning, design, implementation, technical assistance, and capacity building in more than 55 countries worldwide in FPRH, MNCH, HIV and AIDS, and malaria. We're very fortunate to have his perspective today on this important topic. And I will pass it over to you now, Alain. Thank you.
Be able to identify high impact practices and post-abortion family planning using those criteria have been selected as some of those high impact practices. So following that, there was a consensus that was developed in our community around immediate postpartum and post-abortion family planning to focus on providing contraceptive counseling and services as part of facility-based delivery or post-abortion care prior to discharge. So based on that agreement, indicators were developed. That was back in 2017 with a committee set up by FP2020 at that time. And countries agree to track and the use of those indicators to monitor their progress. So 6 years later, we are here today and we have made some good progress in family planning in our region. But overall, when you look at the road ahead from the FP2030 goals and the OP, the Ouagadougou Partnership goals, we are really behind, and for a number of reasons. And it includes weak health systems. It includes or difficulty setting up those NHMIS policies and processes, some implementation hurdles, etc., etc. However, I've noticed that there are opportunities right now in our region because of the free family planning, universal health coverage policy that are being developed, the increase from the DHS in facility deliveries and ANC visits, and also the expansion of community approaches. So all those opportunities, I think, will help us move forward with this agenda. So I'm very pleased today that we have an opportunity to hear from three country experiences, Burkina, Nigeria, and Rwanda, and learn about their effort in tracking and monitoring the postpartum family planning and post-abortion family planning activities, and how they've set up the indicator in the country and into the health system in order to provide a strong base for the expansion. So before we hear our panelists, I would like Yusuf Nuhu, who is a senior advisor for advocacy in the Northwest Central Africa hub of FP2030, to maybe give some brief remarks around those indicators and how they came about and what was the hope when we designed them together as a community. So Yusuf, you have the floor.
Thank you very much, Dr. Allen, and good morning, good afternoon, and good evening, everybody, from wherever you are joining this webinar. As mentioned by the moderator, the recommended indicators have been in use for quite a number of years now, but it will be judicious to understand, where we are in their use for measurement at country and global level. So before going into the country experiences that are going to be shared by Rwanda, Nigeria, and Burkina Faso, it will be important to remind us what these indicators are. Also, as mentioned, the measurement committee set up under the aegis of the Postpartum Family Planning Community of Practice recommended the immediate postpartum family planning and post-abortion family planning indicators that are appropriate for routine collection in national health management information systems under a number of assumptions. Some of these assumptions, included the fact that the indicators should measure coverage and utilization, and also that the indicators are easy to collect, so that they don't, really disrupt the system, and their feasibility of collection will be through modifying existing registers. And then lastly, another assumption is the fact that the indicators are appropriate for aggregation at district, national, as well as global level. So let us see what these indicators are. For immediate postpartum family planning, on the left-hand side of the screen, we see two indicators. The first one is tracking number and or percentage of women who deliver in a facility and receive counseling on family planning prior to discharge. This is disaggregated by age group in two categories: those that are under 20 years of age and those that are 20 years and above. The second Sorry, I went off for a while. The network is a little bit shaky here. If I may continue, the second indicator is number or percentage of women who deliver in a facility and initiate or live with a modern contraceptive method prior to discharge. Also disaggregated by both age and method type. Recommendation considered the feasibility of collection of these indicators and also the fact that they also provide a snapshot into performance of postpartum family planning programs. It was advised that indicator disaggregation to be minimal. So as you can see, we have age for the counseling indicator, as well as age and method type for the optic indicator. The aging disaggregation is important, to especially where there's high adolescent, birth rate. And the method in disaggregation, is there to ensure that there's no skew into one method. Both indicators can be used to ensure quality of service and as well as ensure equality of access, especially for women that are, adolescents. For post-abortion family planning, like we all know, research has shown that clients who are, counseled and are provided contraception as part of post-abortion care, they most likely opt to leave facilities with an effective family planning method. So for post-abortion family planning, we also have two indicators. The first one is percentage of post-abortion clients who were counseled on family planning. This is also disaggregated by age for women that are under 20 years of age versus women that are 20 and above. And the second indicator is percentage of post-abortion clients who leave the family facility with a modern contraceptive. Again, just like the immediate postpartum family planning indicator for optic, this is also disaggregated by type of method as well as age group, for those that are below 20 years as well as those that are 20 years and above. It is important to highlight that integrating all of these indicators into health management information systems and tracking progress will contribute to making better decisions on immediate postpartum family planning and post-abortion family planning programs in the areas of planning, making course corrections in programs, as countries, promote acceleration towards attaining their family planning goals. Thank you very much for listening.
Oh, yes.
Thank you, Yusuf, for that introduction. Do we have our colleague from Rwanda, Dr. Regis? Is Dr. Regis with us?
Thank you, moderator. Dr. Regis. Hello, can you hear me?
Yes.
Yeah, Dr. Regis was in another meeting, but I can present on his behalf. My name is Marie-Claire Edjanyawera. I work for UNFPA as a government partner in family planning and in other areas related to sexual and reproductive health.
Thank you very much. So we are really pleased that you stepped in and you are available to share with us the experience of Rwanda. Tell us about how Rwanda has been addressing postpartum family planning and post-abortion care, post-abortion family planning in Rwanda, and how you are setting up measurement and how you are measuring progress and how you have integrated this activity into your health information and management system.
Yeah, thank you. If we can put the next slide. Yeah, so as you can see on the screen, next slide. I'm going to give you an overview of Rwanda context and also give you an overview of how we are integrating. We have introduced PPFP, our journey to introduce the indicators are integrated into our NHMIS. Next slide, please. Next slide. See the Rwandan population and how the more than 65 are youth below 30, the population density, which increased to 503 per square kilometer, and the population growth and the fertility rate that decreased from 4.2 to 3.6. Next slide. So going through our journey of PPFP. Next slide, please. Yeah, on the screen, you can see our journey for PPFP in the country. I'm going to focus on in 2021 and 2014 when we were piloting the postpartum IUD. It was a project-based program, but in 2015, when the WHO released the new medical eligibility criteria, in Rwanda, under the leadership of the government, we were able to adapt the new eligibility criteria in the Rwandan context, and we started aligning the medical eligibility criteria with family planning training manuals with the revised WHO medical eligibility criteria. And that helps us to develop our new strategic plan. We developed in 2018 the first ever reproductive maternal, newborn, child, and adolescent health policy and the new strategic plan. And at that time, we were privileged to have an evidence produced by Avenir Health, Track 20, which helped the country to know the key high impact interventions, including PPFP, and that helped to consider postpartum family planning as a key high impact and that helps in our strategic document. PPFP is in strategic plan, in family planning guideline, in national commitment for ICPD, and also for family planning 2030. So by time we had the strategic plan, we didn't have a pilot phase. We scaled up the PPFP across the country. Starting from the districts where we have introduced the PPIUD, but now the PPFP is scaled up in all health facilities. Next slide, please. Next slide. So this is to show how PPFP has been identified as a key high impact intervention, showing that if we scale scaled, it can contribute to 19% of modern contraceptive prevalence rate per year. This is the results from family planning goals modeling that was done in 2018 before developing the strategic plan for family planning in adolescent sexual and reproductive health. Next slide. Next slide. Next. Yeah, I'm happy to let you know that when we were revising our national documents, we also thought about the indicators. The country adopted the indicators that were proposed on PPFP, and the adoption of PPFP before discharge indicator. It was prompted by the significant number of women receiving antenatal care and the high rate of deliveries at health facilities. Because in Rwanda, we have high rates, and now it's straightforward to correct, because even the data collection tools, including the files, the client files in the registers, have been revised, and across all health facilities, including the hospitals, the health centers, and the health posts, they are all using those revised data collection tool. So it's straightforward to correct, because the denominator represents the number of deliveries, and the numerator includes clients who receive family planning method before discharge, including those who have undergone post-abortion care. So in Rwanda, we don't have a distinct indicator for post-abortion cases, but those who have post-abortion care, they are also cancelled and they receive family planning before discharge. The correction of this indicator within the NHMIS, it started in 2017. Next slide. Next slide. Okay. This is to show, I will not take long on this, because yeah, to use to adopt family PPFP and also adopting the indicators into NHMIS enabled the country, the government of Rwanda, with partners to monitor whatever is being done for family planning, and it is also contributing to a number of achievements, including maternal health indicators. As you can see on this slide, for maternal mortality ratio, we moved from 1,071 in 2000, and we are now to 203 in 2020. And for skilled birth attendance, you can see how trend is, and antenatal care, and also delivery at the health facility. So allow me to share also some PPFP drivers in Rwanda. So for us, you can move to the next slide. So for us to be able to reach wherever we have reached, the political will is one of the key driver, because government of Rwanda has been taking the lead, being at the forefront with the ownership at all levels, from central level throughout the generation of evidence, throughout the development of policy and strategic plan, and also adoption of PPFP indicators was not an issue, because the whole process was spearheaded by the government. Another key driver, it's an evidence-based policy target that was the evidence that was generated. It also inspired from the high level to the lower level, to understand why we should consider PPFP and as a key strategic intervention, and how useful is to monitor the progress. The commitment by various partners as well, because they were collaboratively working with the government to support either capacity building of healthcare providers, tools, data collection, NHMIS indicators. Yeah, it was really a collaborative effort, and also daily data visibility and monitoring mechanism, because we on a monthly basis we produce reports, and in family planning technical working group we can monitor how trend is. I'm happy to share with you that there is also a WhatsApp group for all in charge of family planning across the country. who, and on a daily basis, monitors to know how many deliveries and how many clients have received PPFP. And that WhatsApp group, that daily monitoring help us to know why this number of deliveries and why you are not providing PPFP. What is the issue? And as my previous colleague said, we start counseling in antenatal care, and before discharge, they need to report on how many women were discharged with the PPFP method. So this was to show you how the process of PPFP was done at the district level. You can, okay. So it was just to share with you how PPFP is embraced as not only a health-related matter, but also something related to sustainable development. So on the screen, you can see the process of PPFP at district level. I don't want to take much on this. It was just to show how from the district stakeholders to improvement of indicators, which process we went through, and who are involved, how we are involving the beneficiaries to provide the communities, how we form the champions, how we form the mentors, and the mentors who on a regular basis visit the health facilities to see, to monitor, but also to continuously build the capacity of healthcare workers PPFP. Next slide, please. Next slide. So as key achievements, since we started in 2017, as I have highlighted that the NHMIS indicators were integrated in 2017, you can see on the slide that we moved from 48% of MCPR to 58 in 2020 for modern contraceptive prevalence rates. You can see how the unmet need for family planning reduced from 19 to 14, and how Rwanda fertility rate decreased from 4 to 6.6. On the next slide, and family planning cross population segment in as the immediate postpartum, you can see method on the 2014, as per DHS 2014, you can see that the injection were the most used. But in 2020, as per 2020 DHS, you can see that how we shifted from the injection to be most of use to implants to be most of use. Yeah, because most of because the implant on the long-acting method are also used in postpartum, in immediate postpartum. So if you can see the trend, immediate modern postpartum use per month, preceding the survey dates, you can see how the trend was. So on the next slide, before we discuss on the challenges, you can see how from 2017, we moved from 17% of PPFP to 67% of PPFP. This is a good progress, and as I have highlighted, one of the key drivers is the government putting this, the government being at the forefront and owning the whole process at all levels. So if have the achievements, we can't miss challenges. Some challenges are related to rumors and the misinformation about some method, and we still have some weakness in data management, because even if the indicators are integrated into NHMIS, but yeah, we are still having some healthcare providers who don't report, and that is still a gap. And but through monitoring and also continuous positive supervision, we try to address it. Those are challenges that maybe I don't want to delay on that. Maybe some, let me highlight that we have faith-based facilities that don't provide modern contraceptive method. So to address this, the government of Rwanda, in support with the partners, trying to establish health facilities nearby the faith-based facilities, so that the clients who need the modern contraceptive method can have those methods. And also in line with that, to address that issue of not providing the modern method in faith-based facilities, we are introducing innovative financing approach to support the private entrepreneurs who can establish the health posts that can be closer to the community. And those health posts also provide all the services, including delivery services. And in those health posts also, they provide PPFP. The healthcare workers who work from there, they are also trained. It's a partnership, it's a public and a private partnership. They are also trained, they are empowered on PPFP, and they get the products so that they can provide PPFP after delivery. So as a way forward, we continue enforce the ownership and a continuous mentorship because of staff high turnover. We address it through continuous on-site mentorship so that a number of healthcare workers can be empowered on the provision of PPFP, and they also increasing method choice so that we can address, we cannot miss any opportunity for a woman who may need to use any method, any modern method after delivery before discharge. So thank you so much, and sorry for the inconvenience of missing Dr. Regis because he was in another meeting. Thank you so much. Over to you.
Thank you very much. Thank you for sharing the Rwanda experience. It looks like you had outstanding results in such a short period of time, and it also appears that you have been able to create synergies and close coordination with all the partners in the country. And the other thing that was impressive to my mind is the strong leadership by the government and the Ministry of Health, and the whole health sector getting behind this initiative. So I don't see questions in the chat. Let me double check. Do you still hear me? Yeah. My question to you is, what was the role of the community health workers in this program in Rwanda?
Yeah, thank you. Maybe I didn't highlight that, but the community health workers play a critical role in terms of raising awareness at the community level, but also following up the pregnant woman, because we have more than 3 community health workers at each village, and who are empowered on polyvalent model. Here in Rwanda, we have redesigned the program, and now they are empowered on 14 competencies, including maternal health related competencies and also family planning related competencies. So the community health workers, they are trained on all methods, and they are empowered to raise awareness at the community level and also to provide counseling to the pregnant women, because they follow the pregnant women, and also after delivery, they continue raising awareness and empowering the couples and the family to ensure that they adopt a method before discharge. And also, whenever the woman get the service after discharge, the community health workers continue to follow up those women and also the families to ensure that they don't miss any appointments, if depending on the appointment the person got after discharge. So one of the role is raising awareness during the period when the woman is pregnant, and also ensure that the couple or the woman choose the method to use after discharge, and also to ensure that she doesn't miss any appointments.
Okay, I think the line is not.
Also, as
yeah. Go ahead.
and
finish.
also they are also provided. Sorry. Hello.
Hello.
Yes.
Okay. Yeah. So this is what we are going to do. We have a time constraint, so I'm going, as the moderator, I'm going to make an executive decision. So let's go ahead. I see that there are questions coming in. Let's go ahead and listen to the Nigeria experience, and then we'll jump to the Burkina experience, and then we will see, we will spend the rest of the time with questions. So keep sending your questions to the chat, and then we'll try to address them at the end after the two other presentations. I don't want the two other countries to not have a chance to present if we start a long discussion on the Rwanda presentation. So the next presentation is going to be from Dr. Olufunke, who is the Senior Director for Primary Healthcare Global Strategy at the Clinton Health Access Initiative. She is also the Director of Programs and Lead for Sexual, Reproductive, Maternal, Newborn, and Child Health Portfolio. She was, before CHI, she was health economist consultant with UNAIDS and also with WHO. She has a bachelor in dental surgery and a master's degree in international health. So Dr. Olufunke, go ahead and share with us the Nigeria experience with postpartum family planning.
Thanks, Alan, and hi, everyone. Welcome to this webinar. I'm really excited to be able to speak on our China-Nigeria experience supporting the Federal Ministry of Health to routinize postpartum family planning in Nigeria. Next slide, please. So I will just give a little bit of a background on the program, some of the achievements and the results, and how we worked with the Ministry of Health to integrate some of the indicators into our National Health Management Information System. Next slide, please. So, Nigeria has a lot of its issues, especially related to maternal and newborn health. We still contribute a significant burden to the global number of deaths, preventable maternal deaths. And a huge driver of that is also the fact that we have very high total fertility rates. More importantly, a lot of women still continue to deliver outside of the health system. So we have over 60% of our deliveries that occur at home. In the 3 states where this program was implemented between 2016 and 2019, Kano, Kaduna, and Katsina, these are located in northwestern part of Nigeria. They're also some of the most populous states in the country, and together they accounted for roughly 20% of the maternal and neonatal mortality burden of the country. I think another critical thing to flag about our 3 states is the average proportion of deliveries that take place at home as of the time when we were doing this program, was about 80%, and it was as high as 91% of home deliveries in Katsina State, which meant that if we were going to work with the state government to take advantage of the benefits of reaching women during the postpartum period to be able to, provide family planning services of their choice, a lot of the work also entailed working very closely with community influencers, traditional leaders, and strengthening the linkages between community health services and the facility where the postpartum implant and IUD services are provided. And so the key objectives were, one, to increase the access points. At the beginning of the program, very few facilities in these 3 states were providing any postpartum family planning, even more so the PPIUD within 48 hours post-delivery. We also had a goal of training up to 1,500 healthcare workers to have the skills and the competencies to be able to insert immediate postpartum IUDs. And at the time, the WHO had just updated its guidelines for implants, which also meant that you can provide implants within the 48-hour period. And finally, there was a huge emphasis on reaching as many of the women who are attending antenatal care and trying to retain them so that they can deliver in the facility, where they would then have the opportunity to receive postpartum family planning. Next slide, please. And so at the end of the program, some of the critical achievements had to do with, first and foremost, if we were going to be able to serve women who had been counseled and wanted these services, it was important that we actually did some work with strengthening linkages between, or I would say integrating service points. As many of us are aware, in many facilities in our part of the world, you have a situation where services are very verticalized and fragmented. And so we reorganize clinic workflows to ensure that every touch point where a woman comes in contact with the system, whether it's maternity ward, whether it's coming with their newborns for immunization, or whether it's postnatal care, they had an opportunity to be counseled, but also to be referred to get the service. Maternity in particular, we had to do a lot of work to ensure that family planning commodities were made available in the labor and delivery wards. And we also trained the nurses and the midwives who take delivery on PPIUD insertion, also recognizing that, that 10 minutes post-delivery period to 48 hours was a critical time point. We worked with the government as well with updating guidelines and healthcare worker protocols, as previously mentioned. The other critical thing to flag was the work we did with traditional birth attendants. In these parts of Nigeria that we were working, over 50% of deliveries that are happening at home are assisted by TBAs, and that's our reality. And so it meant that these are the community agents that people trust, and the women, relied on them a lot. And so it was important to work with them to strengthen their own knowledge of the benefits of postpartum family planning, also to be able to identify, cases where people may require post-abortion care, and to ensure that they were referred appropriately. And that strategy was quite effective because, as I will show later on in our slides, of all the immediate IUD insertions and implant insertions that this program achieved, 25% of the IUD insertions were actually for women who had delivered at home but had been accompanied and referred by TBAs to the facility within the first 48-hour period to be able to get a method of their choice. Next slide, please. At the time, there were no routine data tools, so we didn't have a government register for tracking postpartum family planning, which meant that this project had to set up, program-specific tools, and we worked with the relevant governments at both national and state level to set up these tools, identify a ton of indicators at the time to be able to effectively monitor and track how women were being referred and how women were being counseled and how many women were receiving the services that they chose. This is just an example of some of the program indicators that we collected, to the extent of also trying to determine the facility insertion rates, which is the proportion of women who deliver at the facility who take a PPIUD or implant method before discharge. Next slide. And so just a snapshot of our results. Over the 3-year period, we recorded over 55,000 insertions that were conducted. And as previously mentioned, about 25% were for women who delivered at home and came into the facility to obtain that PPIUD method. On the next slide, you would also see that we had, next slide. On the next slide, we had over 80,000 implant insertions during that same postpartum period of 48 hours, and 34% of them were among women who had also delivered at home and had been referred and came in within 48 hours. I forgot to say that one of the strategies to ensure that women who had been counseled and opted for a PPFP method but delivered outside of the facility was to strengthen the referral transport system, building on a previous program that CHI had implemented for maternal and newborn health. So there were motorbike ambulances, and there was a partnership with NURTW, which is the National Union of Road Transport Workers, to get women transported to facilities. And so one of the things we did was just to expand the scope from not only women with complications during delivery, but women who had delivered and wanted to get to the facility. And we saw this as an opportunity to even integrate, RI services, routine immunization, particularly for the birth dose, to ensure that the babies could also receive their immunizations as part of that mother's visit to get the postpartum family planning service. Next slide, please. And so towards the end of our program, we worked closely with the Federal Ministry of Health based on the experience and, what we had learned from doing this work in the 3 states, and also leveraging some of the work that was already being done and had been done by the community of practice to define these core indicators. We supported the government to incorporate critical routine PPFP indicators into our NHMIS registers. It was also an opportune time because the government was at the time reviewing the registers. We usually review the registers and update them every 3 or so years. And so we were able to work with the government and other critical partners. So this wasn't just CHI, but other partners who support sexual and reproductive health in the country were also part of the process. And through a series of meetings and workshops, the government adopted these 3 indicators that you can see on the slide. So you would see that the labor and delivery register now tracks data on women who deliver and receive a PPIUD method at the point of discharge. And then our family planning register and the ANC registers also include information on women who are counseled on PPFP and women who receive PPFP. Next slide, please. So this is just a snapshot of the family planning register and the inclusion, which shows the type of family planning client. So in that field, the healthcare worker will indicate, having put in all the other information, they will indicate if the patient was a routine family planning patient, or if it was a postpartum family planning patient, or if it was a post-abortion care. And then when that information is summarized into the DHIS2, you're able to pull out the indicators that are related to the percentage of postpartum clients that receive an IUD Jadel implant method, and generally how many women were counseled on postpartum family planning. Similarly, from the labor and delivery register, we were able to include 2 columns there that talk about women being counseled in the maternity ward on postpartum family planning, and then women who actually took a postpartum family planning method. Next slide, please. And so since 2020, the data is now routinely available, and you can actually go into the DHIS and pull out information on the number of PPFP insertions that have been conducted across the country. And as you can see, this was pulled out 2 days ago as I was preparing for this presentation. We have over 680,000 reported postpartum family planning insertions that have been done. In our 3 states that we supported, they account for about 28% of these 680,000 insertions. I think just to flag that it's now routinely being reported, and there's still a lot of work that the government is doing with CHI and other partners to continue to build capacity and strengthen the data reporting as well as the quality of the data that is being reported. And to my final slide, just on some critical lessons that we've learned. Next slide, please. On the critical lessons we've learned, to summarize, the need to integrate services is really critical for postpartum family planning, and recognizing the different access points where a woman can be counseled and also be offered the method to choose. Ensuring commodity security is big, not just for family planning clinics, but also for PPFP. You want to think about, how do women who are delivering and have been counseled and want to take that method, how can we ensure that the commodities are in the ward where they are delivering and that the service can be provided immediately after birth. There's still a lot of work to do on improving the quality and through DQAs, but also refresher trainings for health workers. We've sometimes seen situations where when healthcare workers are changed, the new healthcare workers don't fully understand and they may be misreporting or under-reporting services. And then, as I had mentioned, the importance of referral, given that in our context, a lot of women continue to deliver outside of the healthcare facility. That means that we're still not capturing as many, there's a missed opportunity, and there are many more women out there who, if offered the choice and if appropriately counseled, may be choosing to obtain these methods. And that brings me to the end of the presentation. Happy to take any questions. Thank you.
Thank you very much, Dr. Olufunke. That was great. I think, as I said earlier, I'm going to go ahead and ask Dr. Chek to present, and then we'll open the floor for discussion. So Dr. Chek Wedrago is an expert in reproductive health and family planning. He's currently the director of the Sexual and Reproductive Health Project in the Jipaigo, Burkina Faso office. Before that, he worked for PSI, Population Service International. He was also a regional advisor for IPPF in the Africa office in Nairobi. So Dr. Chek, please share with us your experience in Burkina, setting up postpartum and post-abortion care, family planning services, and how you documented your progress.
Ok, bonjour tout le monde. Merci Alain. J'ai le plaisir de partager l'expérience de Burkina.
Thank you all. It will be a pleasure for me to present the experience of Burkina Faso regarding PFPP and PFPA. Slide, please. This is the plan of my presentation. I'm going to talk about the context and the adaptation process and how we take into account the indicators for PFPP and PFPA in Burkina, the use of indicators for the follow-up of progresses at the program level, challenges and perspectives, and conclusions, please. As I indicated, the context reveals that for years, Burkina Faso had adopted family planning at the level of the various indicators for the health system, that we had good indicators, robust indicators, compared to what we were seeing in terms of postnatal results. And this was an opportunity for all to have access up to 80% to these systems. After the 2020 conference, Burkina Faso has adapted its program, and GHPIEGO has accompanied the ministry on the postpartum field with the support of UNFPA. At this level, we already have in place a system to register data. We also had register forms, and we devised a database to use these data. Then there was a durable activity system for the same period, which aimed at reviewing policies and protocols for the postpartum family planning services, as well as integrating training on family planning, postpartum, and post-abortion. There were a number of training for agents and the impact of PFPP in the National Family Planning Action Plan. There was a strengthening of services provided in the context, integration of indicators for PFPPs in the SNIS in 2016, and integration of indicators of SAAA and PFPA in 2019.
Next slide. So the adaptation and inclusion of the indicators into the HMIS in 2016 and 2019. This, we worked with JPIGO on this, and we worked at the national level in order to include and integrate these indicators. We included 3 indicators: the percentage of women who have given birth who receive contraceptive counseling immediately postpartum, the percentage of women who have adopted a family planning method before they leave the maternity ward, and the third is the percentage of clients of post-abortion care who have adopted a family planning method. Next slide. So with regards to methodology, we have the steps in the process of in the integration process. We have the selection of indicators, which was the first step. And we looked at the indicators for PPFP and PAFP. Then the second step was to review the different data collection tools. And we wanted to take into account our new needs for information with regards to these indicators. The third was integration of these indicators into the HMIS. After we chose the tools and after we integrated the indicators into the HMIS, then we moved into selecting the indicators, integrating them into the HMIS. We moved to the 5th stage, which was to integrate the indicators into the HMIS. Next slide. So after that step, we had to review the records that were involved in the HMIS, and we needed to integrate the variables that are related to family planning, both postpartum and post-abortion. We needed to work with the ministry. We needed to configure the indicators. Then after that, we needed to work on the different tools in order to make them available to health facilities. Then we had to train managers. Then we had to train nurses and those who are working in the different wards and units of the hospital. So this was the process that we used in order to integrate these indicators into our work. This was a very participatory process. We tried to involve all of the different stakeholders throughout the process. Next slide. So we were able to work with the different health facilities in order to perform a review of the indicators. The interpreter cannot hear the speaker. Each health facility was able to follow these different indicators and was able to do its own follow-up on data collection. We got a regional progress report at the district and regional level, and we were able to validate the data that we received. This allowed us to identify the different gaps and places where we were missing information, as we were able to work to improve the platform and make it easier to collect data. We worked with a steering committee in order to develop a family planning plan for Burkina Faso. At each step along the process, we updated this steering committee in order to tell them about what we had done, how we had worked on the integration of these indicators. And we were able to present the work that had been done and the work that was still left to do. We also worked on planning and project review with different NGOs and other partners. We did this at the national level and with organizations. Next slide, please. So as I was saying, with regards to the adaptation of the indicators, we were able to update data collection tools and reporting tools. We worked on our counseling records, our family planning records, our childbirth records, and monthly activity records. We were also able to configure the DHIS2 to include the new indicators. And we also created a dashboard in order to monitor these indicators. So this that you have is an example. It is a record of a childbirth and a family planning record that you see on the right of the screen. We also tried to look at the different variables in this. Next slide. So this is a graph that shows the use of these services. We started to implement this project in January of 2016. And so this is the data from 2016 to 2020. And a significant portion of women chose to receive a long-acting contraceptive method. So as you can see, it went past 20% by March of 2020. But for women who received any method, we saw a significant increase. But we did, in fact, see an increase in the choice of long-acting methods as well. So we took into account all women who had just given birth. Next slide, please. So let's talk about the challenges. We did face many different challenges in order to ensure the quality of the data with regularly scheduled audits. So we needed to make sure that all of the actors involved in data collection were trained to do it properly. And we also we noticed that there was a difficulty with the inclusion of PPFP and PAFP in the annual statistics. So we noticed that, and we knew that we needed to work on that. We also wanted to make available the data collection tools, or the new data collection tools in the NHMIS, and we needed to train, and we needed to make sure that these were involved in health facilities and that they were available on a permanent basis. Even though these indicators had been integrated into the NHMIS, all of the facilities don't offer these services because the service providers are not necessarily trained in it. So we need to make sure that the services were offered by the providers on the ground. And we need to do that and to make sure that we had a higher impact. Another difficulty was related to the fact that not all of the service providers had been trained in collecting this data for the HMIS. We needed to scale up the training, and we needed to scale up the data collection. When we're looking at the postpartum and post-abortion periods, we wanted to make sure that these periods were also noted and indicated into the data. And we need to make sure that the providers were skilled at providing these services. Next slide, please. So, for the future, in order to make sure that we continue offering quality services, as I was saying earlier, we need to make sure that this is a sustainable change and a sustainable program. We need to make sure that we have all of the necessary tools in place. We need to mobilize financial resources in order to build capacity and help train providers. We also need to improve, we need continuous approval of data collection for the HMIS and the use of these data. We also need to strengthen our electronic data management system at the national level. So this is also a challenge. We have started working on it, but it is true that at the community level, we still need to work on developing and strengthening this system. So we have finished configuring all of this at the national level, and with that, we can start to highlight the postpartum and post-abortion periods within the data. Next slide. For conclusions, the integration of these indicators in the HMIS, that will allow us to monitor these indicators at all levels of the healthcare system. We have also noted that the use that we have breathed new life into using IUDs. We've gone from 4 to 10% on the ground, and we have improved the performance of the PPFP offer of services. We have also created a sense of ownership of the indicators by the service providers for PPFP and PAFP. We have also been able to improve the performance of PAFP service offerings. We have passed from 0.1% to 41.3%. So these are our conclusions, and that is the information about our integration and inclusion of the indicators in our HMIS. Thank you.
For this very good presentation. I think I really wanted us to hear from the 3 countries, because that's really news from the front line, and they've done it, and it's great to hear from them how they did it and what lesson they've learned, what challenges they faced, etc. So we have a few minutes for question and answers. I've seen that each speaker has a few dozen questions. So what I'm going to ask Knowledge, Success, and some other colleagues here is to make sure that we ask the presenters to type in the answers either in the chat or in the tool that we have, so that this can be distributed to those who participated in this webinar. So answers could be available, within the next few days, if presenters are able to help us with that. But I'm going to go through some of the questions that came up in the chat box. I'll ask Marie-Claire, Rwanda. So Marie-Claire, one question is, can the Rwanda presenter elaborate on how they count post-abortion family planning? She said post-abortion family planning clients are counted, but not separated from postpartum family planning. So it wasn't clear, are the post-abortion care services in the labor room or in the maternity? Like how do you combine the two into your register and then report back out? I think that is the question. How are you able to combine these two numbers, post-abortion family planning and postpartum family planning? Because I think you mentioned it's one in Rwanda. The second question for you is, how is the government ensuring that commodities...
Comment est-ce que le gouvernement peut s'assurer que les produits sont disponibles dans la salle d'accouchement? C'est une autre question qui a été posée dans plusieurs endroits où il est très difficile que
contrast commodities in the labor room or in the maternity area. Women have to go to another space, another location in the compound to get their family planning services, which is not always convenient. So how did you ensure that those contraceptives were available in the maternal newborn health area? So let me start with you, Marie-Claire, for these two questions. Yes.
Thank you. I'm Joel Seruchacha. I'm in charge of family planning in Rwanda. The collection of data at the same time for the post-abortion and family plan and the postpartum family planning. We use the same register for all family planning, even in the postpartum and in the general family planning. Reason why we have not put more information on data collection, and we, as you know, the post-abortion is done at maternity, and each woman, as recommended by WHO, the woman can be pregnant after 6 months. Reason why the method received at in the postpartum is the same. And in our method mixed, you will see, for example, the injectables in the postpartum. This can give you the why the injectable in postpartum, in immediate postpartum, and some women who take other method, we don't know if it is in a post abortion or after normal delivery. It makes the method for the post abortion and the normal delivery. Thank you.
Okay. Thank you very much for your answer. I'm going to go to our colleague from Nigeria. So the question is the following: why collect data only on LARC in postpartum? lamb pop and condoms, and other method of contraception that may appeal to some users. So why not collect those data? And I'm giving you a second question. So the second question is really, please share the way you tackle the social culture that the mothers do not want to visit or leave home up until 49 days of birth. So Dr. Funke.
Yes, thank you very much. So for the purposes of the program, the goal was to increase the uptake of postpartum long-acting reversible contraceptives. And that was why we emphasized collecting the information on women who were opting for IUDs and implants. However, for women who wanted shorter acting methods, those were also very much available, and they were captured in the regular routine family planning register. To the second question about the culture, as I mentioned prior, so we worked very closely with the community influencers, right? And in this particular case, the women who often are at the point of delivery, assisting women who choose to deliver outside of the health center. And part of that entailed, working with these TBAs and community influencers to understand the benefits of postpartum family planning, but also the benefits of postnatal care and the benefits of immunization for their children, which means that if they're going to be able to choose to take those services, then they would have to get to a facility within the required period, shorter than the 40 days that the tradition usually requires for women to stay at home before they go out post-delivery. I wouldn't say it was 100%, perfect. I mean, there was working with community influencers, but there's also the male engagement piece that was necessary, letting men understand the importance of these services on the health of their wives, their sisters, their daughters. And that was also relevant in engaging with the community leaders and the traditional and religious leaders in these communities to be able to sensitize them on the need to allow women to access the services. One of the major barriers that came up was the issue of getting to the facility. So yes, there were concerns with the traditions, but there's so much, orientation, sensitization that is already happening in our communities, especially for routine immunization and family planning, that it wasn't convincing women on the need for uptaking the services in that 48-hour window was not as challenging as their ability to get to the facilities to be able to get the service, which was part of why we then built in the referral piece to ensure that women were appropriately linked to adequate voluntary transport providers so that they could get to a facility and receive the method and get back to their homes with little or no cost to them. Over.
Thank you very much. Now I'm going to Dr. Check. Je vais lire la question en français. Dr. Sheikh, j'aimerais mieux comprendre.
Dr. Sheikh, I would like to better understand the specific process that you follow to include family planning indicators post-abortion in the health information system. How did this process differ from the postpartum family planning indicator integration? Have you made a difference between the two efforts? Was there a different approach? We would be interested in finding out the lessons that you drew from the inclusion of these two indicators in the National Health Information System. Second question, you talked about the training of providers. The question is to find out whether the community that was served was that community ready to receive these new services? What was the reaction? Thank you. Sorry. Thank you very much to our moderator for this question. The introduction process of these indicators for postpartum family planning, the indicator already existed. It simply was not recorded. when we talk about abortion, you know, for a lot of people, it still has a stigma attached to it. And then there's a legal issue. So the legal issues in terms of service provided in a post-abortion situation can be very delicate. So there is that fear. There is this stigma, and the result is that providers don't want to discuss it. As a result, we needed an opportunity to work with training centers to clarify values for providers so that they become part of the system and understand that post-abortion family planning measures are important. And this is measured according to the number of women who come for a service and leave with a method. So that represent about 70% of the women. 70% of the women who come for a service leave with a contraception method. What is this indicating? It shows that the method is not different compared to postpartum family planning, but we had to work on the provider level. So, and in the framework of the pilot project, we created forms and we had monitoring with providers on a monthly basis, as well as I mentioned, we created a database. So it was a little more difficult in the case of the post-abortion, but we followed the same approach. And that showed the importance of having these indicators for the post-abortion family planning. So people must go through counseling first. And in Burkina, we also needed to make sure that commodities, products were available in the rooms so that women don't have to leave and come back or go somewhere else. And on the second question, as far as providers, for healthcare community agents, we have done training, awareness creating, awareness raising, thus creating demand at the community level, and a number of prenatal consults, for instance, include explanations and information about family planning. And in the register, we see that family planning is indicated as an element that needs to be covered. So within these communities, this is what is important. We need to have family planning available, discussed, so that we make sure that the mom is doing well and has the information she needs. So it is the community, the health agent at the community level that do the work. This is how women can benefit from this information, and this is how communities benefited. As far as abortion, progresses have been made, and we have used opinion leaders, religious leaders, faith leaders, who discuss post-abortion services as a health service. Thank you, Dr. Sheikh. Allow me to ask Alison and Isaitu whether we still have a few minutes or we should conclude, because it is already 29 after, so we have 1 minute left. I just need to confirm that we need to close now, or can we go over?
Aissatou?
Aissatou, yes. I think we need to wrap up, but reassure the participants that we will answer the questions that are sent, and we will answer by email. So send your questions by emails if you haven't sent them yet, and we will answer. Thank you. That's a great piece of news. So to our entire public, we will have answers to every question that were raised in the chat window. And let me conclude by saying that a number of points came to me as so important. The importance of government leadership and involvement of civil society are crucial. Things should not be done halfway. We need to use a health system approach to make sure that all the little parts, all the elements that are needed to scale up the intervention can happen. I was also struck by one term that was already used last week during the meeting of the Francophone community of practice meeting on family planning for postpartum in other health services, this concept of a one-stop shopping using the systematic identification of the need of the client so that there is no missed opportunity. This entire concept of integration in time and space is absolutely essential. I also heard the importance of the role of community-based agent. In Nigeria, I believe it was mentioned that 25% of the women give birth at home and afterward came to the maternity wards to receive a family planning method. So it is essential to link up from the community to the district strategic level. I also found out that when there is no commodities, there is no program. So how can we make sure that there is availability of all the commodities needed for the postpartum and post-abortion family planning so that we have the products needed where they are needed so that the family doesn't have to come 3, 4, 5 times to the same health structure to receive everything. And the final point is the need to mobilize resources to implement all of this, because scaling up requires resources and not just partner resources, but more and more, I believe, we want to see domestic resources. We want an involvement of civil society. We want an involvement of the various actors. And this is, I believe, something Rwanda mentioned, the actors from the private sector who are helping with a number of the innovations. This, in a nutshell, is what I drew from all this. We haven't really talked much about the private sector, nor have we discussed populations in the Sahel today, which are internally displaced persons or refugees. We haven't talked much about peri-urban areas that are a huge issue at the level of the sub-region, because the urban and rural areas seem to have better organized services than the peri-urban areas. Finally, the issue of definitions. It seems to me that according to the country where we are, sometimes we're talking about 6 weeks post delivery, sometimes 2 years, sometimes 1 year. So we remain a little confused here. We see that countries have different indicators, and at some point, it might behoove us to measure the programs in a way that will allow us to make all of this more consistent, if it is possible. The issue of deliveries, I've discussed this, the ones at homes or at least outside of hospital structures. Services must be available, and the integration dimension must be considered from a broader perspective to avoid missed opportunities. This is the summary I wanted to make. I thank you kindly, one and all, for your wonderful participation. As always, unfortunately, time is too short for our discussion, but I can assure you that this is not our last discussion on the topic. We're going to have several sessions before we meet, hopefully, at the end of 2023, 2024, in persons to discuss at the regional level every single one of these questions. I thank the organizers. I thank you for involving us, and I thank you for every one of you for joining us for this meeting. Thank you very much.
Merci, modérateur.
Thank you to our moderator. Goodbye. Thank you. Thank you, moderator.
Merci.
Thank you.